I'll be speaking on nuclear medicine beyond radioactive iodine. So we all know that RAI is very useful in DTC. It facilitates monitoring, reduces recurrences, improves outcomes, and also improves overall survival. So it has a protective role as long as the tumor retains the iodine avidity. But the challenge arises when DTC loses its ability to concentrate radioactive iodine. So what is this condition known as? This is known as radioiodine refractory differentiated CA thyroid. So RRDTC, it is defined as malignant disease that does not ever concentrate radioactive iodine, or the tumor tissue which was earlier concentrating radioactive iodine but now does not concentrate radioactive iodine. It concentrates in some lesions but does not concentrate in others, or the metastatic disease, it progresses despite significant concentration of radioactive iodine. So this is just a sum total of what radioiodine refractory DTC is. And why does this occur? Because there's loss of sodium iodide expression, which leads to progression of disease, and the overall 10-year overall survival is dismal at 10%. So can we predict a radioiodine refractory DTC earlier? Yes, if there are certain histological features like vascular invasion, extrathyroidal extension, or aggressive histologies. If they show BRAF and TERT mutations. If there is sudden rise in serum thyroglobulin with a doubling time of less than 1 year, and sometimes if you are doing imaging or if you have done FDG PET-CT and the FDG avidity is very high and with a very high SUV max, then you can say that this is the patient who would go into RRDTC. So what is the imaging that we do in RRDTC? So one-stop shop imaging is FDG PET-CT, and once you have done FDG PET-CT, you will see 3 scenarios. One, the patient is asymptomatic, indolent RRDTC. So such patients you need not worry because they can be put on suppressive doses of LT4 and the patient is going to do good. But if the patient is symptomatic, progressive but oligometastatic, you could offer surgery and external RT. The most troublesome scenario is when the patient is symptomatic, rapidly progressing, inoperable, and is widely metastatic. So then comes the challenge. So what do we have to offer? TKI, redifferentiation therapies, whether they help, or there are some nuclear medicine therapeutics which we could offer. So coming to TKI, we have multiple TKIs that have been used, sorafenib, lenvatinib, and cabozantinib. Out of all these, lenvatinib has been promising, but the problem with all these TKIs is that there's a lot of toxicity. The quality of life of the patient is reduced, and they often develop resistance once they are given for not more than 1 to 2 years. They will develop resistance to the drug, and it cannot be given further. Then comes the redifferentiation therapies. Now, redifferentiation therapies we have been hearing since long. Maybe when I was a student, we used to speak about retinoic acid, but that is long bygone, and because of the toxicities, we don't give retinoic acid. The newest kid on the block when we are doing redifferentiation therapy is tremetinib and tremetinib plus dabrafenib. Now, these are given to patients who are either BRAF mutated or wild type BRAF. So this is given for 21 days. So now this is like, this was a phase 2 study where one arm received tremetinib, the other one received tremetinib plus dabrafenib for 21 days. What they saw was that redifferentiation, so the patient underwent radioactive iodine scan, it was negative, therefore this redifferentiation therapy was offered, and then again they did a diagnostic scan and they saw the uptake. So redifferentiation was achieved in 7 out of the 20 patients, only 35% patients achieved redifferentiation, and then they received radioactive iodine. Now, any thyroglobulin decrease was seen in about 4 out of the 7 patients. So 57% of the patients showed any thyroglobulin decrease in when given dabrafenib and tremetinib. Now, 85% of these patients showed adverse events, and transient pyrexia, grade 3, and rash of grade 3 were also noted in 1 patient each. So this also is not without side effects. Also, it is expensive, and most patients are not able to tolerate this drug. So what do we have to offer? So when we do nuclear medicine theranostics and when we are talking of RRDTC, there are certain radioisotopes that we speak of. So PSMA has been spoken about and given in many centers in RRDTC patients, but the uptake is in the tumor neovasculature. So because it has high vascularity, the PSMA will go and sit there, but it is not retained. So as soon as it goes, within a few hours, it's out of the tumor, and therefore this will not have any effect on the tumor, and therefore poor response when we are doing lutetium PSMA therapy. So PSMA is out. Then comes the somatostatin receptors. Now even somatostatin receptors, they show very low expression of SSTR, so the sensitivity is very low, and therefore very poor response to lutetium dotatate therapy. So PSMA and SSTR are out. The next that we have is RGD. Now RGD, it targets integrin alpha V beta 3 on the tumor vasculature, and this is basically an angiogenesis marker. What we have with RGD is that only imaging studies are there, so it shows good uptake in RRDTC, but the sensitivity is also better than FDG. Appears promising, but still we don't have any therapeutic studies which have been published. So the next that we are left with is FAPI. Now FAPI is the latest kid on the block when we are looking at therapeutic nuclear medicine, and it targets cancer associated fibroblast, encouraging results with lutetium FAPI therapy. And let us see what do we have. So fibroblast activation protein, the FAP expression is very low in normal human fibroblast, but this is upregulated in cancer-associated fibroblast and is present in the tumor microenvironment. This is involved in tumor angiogenesis and disease progression. This is again mediated by the BRAF V600 mutation. Now FAP can be labeled with gallium-68 or F18 so that we can do imaging studies, and these are surrogates then, and we could give therapy with either lutetium 177 or with yttrium 90. So fibroblast expression is seen in majority of RRDTC patients. Extent of FAP, it correlates with the degree of FAPI uptake, and the uptake correlates with accelerated growth rate. So this is an example where you're seeing a large, this is an anaplastic CA thyroid and not RRDTC. So this patient is showing a large mass which is avid on gallium FAPI, and you can also see that there are lung metastases which are showing uptake of gallium FAPI. So a potential candidate who can be treated, but then anaplastic, the overall survival is very less, and I don't know how we are going to help this patient, but definitely in RRDTC we could treat patients with lutetium FAPI. So when we are looking at FAPI, there are multiple molecules, and multiple molecules have been used, but whatever is available with you, you could use that. FAPI 46 is the most commonly available tracer, labeled with gallium, which is available for imaging. So it attaches to the FAP extracellularly, internalizes, and therefore is retained intracellularly. So we have some of the imaging studies. Now whatever studies I'm going to speak henceforth is all done by Dr. Bal's group in AIIMS, and they first did imaging study and compared gallium FAPI with FDG, and what they saw was that the sensitivity for detection of lymph nodes, liver metastasis, brain metastasis, lung metastasis, all was higher as compared to FDG, and however the uptake values when you compared between the two tracers was very high with brain metastasis and also muscle metastasis. So this imaging study, if you see here, this is the FDG PET. It's showing only few lung metastasis, whereas if you see at the gallium DOTA FAPI, it's showing multiple mediastinal nodes, the lung metastasis, and also the liver metastasis. So this imaging study done by Dr. Bal, it paved the way for doing further lutetium FAPI therapies in RRDTC patients. So when they started using it, they were doing it in conjunction with Moon et al, and they found that this FAPI, when they were using a monomer, it did not concentrate, and there was rapid clearance of the FAPI agent from the tumor sites, and therefore was not showing any benefit. So structural modifications were done to this monomeric FAPI, and development of homodimeric compounds were done, and these modified compounds then exhibit prolonged retention in the tumor sites. So then this was used, and they did a pilot study where it was used as a salvage treatment option in RRDTC patients who had progressed on TKIs, and lutetium FAPI was given at 8 weekly intervals. So 15 patients they actually did scans in 19 patients, but 4 of them were excluded because they did not show much concentration in FAPI. So 15 patients were recruited. All patients had distant metastasis, and the patients received 2 to 4 cycles. Median cumulative dose of about 200 millicuries with a median follow-up duration of 7 months. So they showed that any TG decrease was seen in most of the patients, and when they looked at molecular response assessment, partial response and stable disease was seen in more than half of the patients. And none of the patients had any grade 3, grade 4 hematological, renal or hepatotoxicity. So this was a pilot study that they did, and the examples they showed was, this is a patient who was RRDTC patient showing excellent uptake on FAPI with a TG of more than 3 lakhs nanometer per ml. And when they treated this patient with 2 cycles of Dotaga FAPI, they saw that the patient had the TG had decreased to about 7,000 nanograms per ml, and as you can see, even on the scan, many of the lesions have responded to treatment. Another thing that they showed was that even after 7 days, now 168 hours after the patient has been given the therapy, you see good retention in the skeletal metastasis. So post 7 days after the therapy also, there's good retention of this tracer, and therefore this is going to be effective. Another example, lung metastasis seen on FDG. This is the FAPI, extensive lung metastasis, and when they imaged the patient for 4 days, they saw that there is good retention of this tracer even 4 days post therapy in the lung metastasis as well. So this preliminary data, it suggested that FAPI is safe and seems to be effective in RRDTC. So he will never stop with that. This study came in 2022, and the next study that was published very recently in February 2025 in the Thyroid, long-term outcomes of radioactive iodine-resistant follicular cell-derived thyroid cancer treated with lutetium DOTA dimer therapy. So this was a retrospective study. 73 patients were enrolled in this study. 65 patients received lutetium DOTA dimer monotherapy, and 8 patients received lutetium therapy as well as followed by actinium therapy. The primary endpoint was progression-free survival and overall survival. And the patients received a median cumulative dose of 600 millicuries. Among these 73 patients, 20 died and 16 were because of disease progression due to thyroid cancer. However, the estimated median progression-free survival was 29 months, and the median overall survival was 32 months. So it's very good when you are looking at RRDTC, when no other therapy is being effective, having a median PFS of 29 months and a median overall survival of 32 months. Few patients had some toxicity, but there were no deaths because of the adverse events of lutetium DOTA therapy. So lutetium DOTA FAPI dimer, it showed promising safety and efficacy in aggressive RRDTC with a median PFS and OS of 29 and 32 months with manageable adverse events. So to sum up, not many treatment options in RRDTC when the disease is very aggressive. Multikinase inhibitors not tolerated well due to the toxicity profile. FAP is overexpressed in the tumor microenvironment and correlates with tumor aggressiveness. Lutetium FAPI has shown promising efficacy with lesser side effects, but larger prospective trials are needed for confirmation. And availability and a cost are an issue. Though it's now available, the cost is very high, and the supply chain is not very efficient. So that's why we have to look at the availability and the cost. Thank you very much for patient hearing. I'll be happy to take if there are any questions.
Ma'am, other than thyroid cancers, are there any potential cancers where this FAPI therapy is useful?
Okay, lutetium FAPI is now used in many other cancers as well, in medullary if it is not showing uptake of SSTR expression and there's nothing else that is left, even for medullary thyroids. For adrenocortical cancers, many other cancers it is used. Because it is a surrogate, you have a gallium FAPI, and because it attaches to the FAP agent that is in the cancer microenvironment, it's useful in multiple other cancers, but usually it is given when there are no specific therapies left, then you will go ahead give FAPI therapy.
So that is for therapeutic purpose, but for diagnostic purpose?
You have to use gallium FAPI, that's a surrogate. Gallium FAPI is an imaging agent, lutetium FAPI is a therapeutic agent.
Okay, thank you.
Excuse me, how do you decide on PET or FAPI?
How do you?
Decide on PET or FAPI?
What FAPI?
FDG PET
Okay. So you have seen disease on, if FDG has been done and you have seen disease on that, FDG PET is just an imaging aid, it doesn't have a surrogate. But if you want to treat or if you're planning therapy with FAPI, you have to image with gallium FAPI first to see the uptake. If there is uptake, only then can you treat with lutetium FAPI.
Okay, FAPI is always therapeutic also?
Yeah, it is therapeutic also.
Thank you.
You have to use which molecule you are using. Yeah. Because when you are using gallium FAPI 46, that's an imaging agent. But when we do it for therapy, there are certain, there are no names at present, but it is like FAPI 2286. I think Dr. Bal has used another one. So there are different FAPIs, and you should ask your nuclear medicine consultant as to which is the therapeutic agent.
Thank you.
Thank you. Anything?
Thank you so much, ma'am. The topic for our next presentation is dynamic risk stratification in thyroid cancers. The presenter is Dr. Poonam Joshi, ma'am. She is Professor, Head and Neck Department of Surgical Oncology in TMC, Attract, Khargan, Navi Mumbai.
So thank you for the opportunity. My topic of presentation is dynamic risk stratification in thyroid cancers. It will be like a summing up of all the presentations till now, and I will try to take you briefly through the this evolution from ATA 2015 to 2025. So as we all know that the risk stratification is mainly comes from the AJCC. We know that TNM classification, now AJCC 8th edition, it predicts the survival, but we know it is fixed. So we put TNM and we make it stage 1, 2, 3, 4, A, B, and then we decide for the survival. However, the dynamic risk stratification, it mainly basically adjusts the risk of recurrence after the therapy, and it is based on repetitive biochemical test and imaging at different periods. So if you see that the dynamic risk stratification is a more powerful predictor of recurrence than the static staging. So we all are aware of this AJCC 8th edition. It's a busy slide. So why should we risk stratify the patients? So we know that it can prevent the over-treatment in low-risk patients. We can identify the patients who may need more aggressive surveillance. We can tailor the TSH suppression accordingly, the dose of radioiodine or the need for it, and the imaging schedules can be planned accordingly. The dynamic risk stratification provides the evolving risk of recurrence, and like I already said, which is beyond the static AJCC staging. So again, we all are aware, we have seen this slide several times, and this is a 3-tier system of ATA 2015 initial risk stratification for the histopathology report, and it tells us the risk of structural disease recurrence. And it basically divides it into 3 groups, the low risk, the intermediate risk, and the high risk. So, however, the dynamic risk stratification, which usually after the completion of the therapy, the post-treatment, the thyroid remnant ablation or the adjuvant treatment, it basically is divided into 4 categories. I will not go into details. We know excellent response, no disease, biochemically or structurally, biochemical incomplete disease, structurally incomplete as the name suggests, there is structural disease, and indeterminate, where the findings are equivocal. So again, a very busy slides, but it tells us that that this response also depends upon the level of thyroglobulin, and it has certain clinical outcomes and management implications. So if we go by 2015 dynamic risk stratification, usually the evaluation is done around 6 months earliest after the completion of treatment, and naturally, like I said in the previous slide, it depends upon the TG values, then TSH suppression levels, and accordingly it changes. So we know there is enough data that by the Momeso and Tuttle studies that the dynamic risk stratification is a validated tool, and it predicts the recurrence, and it prognosticates better as compared to the initial staging, which is the static AJCC staging system. So the tools we all know are serum thyroglobulin, anti-thyroglobulin antibody, various kind of imagings. Usually we use ultrasound neck and CT or PET CT whenever needed. So naturally, every guideline has limitations. Similarly, it has few, like one of the most important limitation was the intermediate risk group, which is large and heterogeneous. The WHO, the classification naturally was earlier one, and the recent one has come in 2022, which has been incorporated in the 2025 guidelines. The timing of first reassessment, this was very important, was actually quite late, around 6 months. So now I think we have been hearing this data framework since the very morning, and we have all gone through it. That data has been incorporated now into the ATA guidelines 2025, and it basically includes the diagnosis, assessment, which is risk versus benefit, risk and benefit, and treatment again, and then you assess the response to the treatment. It looks like more patient-centric model, and it gives you a better framework, it gives you more clarity, and it is more methodical. And here it is done at almost every stage. It starts from the time the patient comes to you. Now when you see the patient, you can stage, okay, now this is the diagnosis, so this is the assessment. So the patient is early stage, now we can assess, and then we can decide, do we need to do surveillance, do we need to do treatment? Though we were doing the same earlier also, but now it has been given in a more methodical manner. So now there have been a lot of changes also in the pathology in 2025, and NIFTP has been excluded from cancer, oncocytic has been recognized as a distinct entity, other from the follicular, and differentiated high-grade thyroid cancer has been added, and there has been some risk alteration. There has been downstaging of certain tumors. So if you see again this busy slide, this basically WHO has been 2025 has been divided into mainly 4 groups: low risk neoplasms, malignant neoplasms with high grade follicular cell derived non-anaplastic, and there are few rare neoplasms as well. So how it is different, this 2025, the definitions are quite clear, and even they have now mentioned that what a thyroidectomy is. Extent of neck dissection have been described very well, and the RAI treatment, that various definitions have been given. So this slide also we have been seeing since morning, and now if you see this 2025 estimated risk of structural recurrence after the histopathology report shows it into 4 tier. Rather than intermediate being one group, now it has been divided into 2 groups. So this grouping is now low and intermediate risk grouping, and they have given particular percentages for the risk of recurrence for everyone, like less than 10% for low, then you go and it is low intermediate is 10 to 15%, intermediate high is 16 to 30%, and high is more than 30%. So this data, again the similar slide. The important slide why I did it here is that again now we are assessing the patients a bit early. So again I'm saying we were doing this, but there was not, it was not put in a methodological manner. And now we can in fact assess the patients at 6 to 12 weeks with thyroglobulin, with anti-TG antibody and imaging. These we know the nadir of this thyroglobulin usually reaches around 3 months, we consider, like 12 weeks, but it can be around 6 to 12 weeks, which is usually the given range. So you can have a good idea like what kind of risk assessment you can do for this group of patient, and then you can take a further call that these patients, do they need radioiodine therapy, or in fact we can even keep for again observation, and then evaluate accordingly as per the risk evaluation. So this is the main slide of the whole presentation, that this is the recent or the 2025 dynamic risk stratification. Like we said, the first slide, now it has been divided, the structural risk of recurrence has been divided into after the surgery or the histopathology report into 4 groups: low, low intermediate, intermediate, high, and high group. And then every group can go to the excellent depending upon the treatment response, which is surgery or surgery followed by the radioiodine adjuvant treatment or ablation, whatever is the treatment. And then it can go into intermediate, biochemically incomplete, and structurally complete. So further they can be further divided into, and they have given percentages for each and everything. Excellent can again fall into low, low intermediate, intermediate, high, and high. So this is the, I think, the crux of the whole I would say the dynamic risk stratification. More or less the things are the same, but again and again I'm reiterating the fact that they have put it in a more streamlined manner. Then again, for persistent and recurrent disease, they have put it into the data setting. So this has been the one slide, and then for RAI, madam already described it very well in the previous lecture, and there have been lot of therapies coming up, and there has been a lot of stress upon the molecular analysis of almost all the thyroid cancers. For even radioiodine resistant tumors, there is a lot of work going on even for the BRAF mutated cancers, where you can even treat them with this trametinib and the dabrafenib. But that is mainly for the treatment setting, and but data is still not mature. A lot of data is coming. We do have enough data now on ATC, but for this it is coming up. So now for 2025, now the risk assessment usually is done at 6 to 12 weeks. That is, we can be done around 3 months, much earlier than the 6 months, which was in 2015. I think that we all know. Accordingly, we can tailor the decision making for the RAI TSS suppression, and if we need imaging for the treatment, for further surveillance and treatment. This is again the repetition. So how these two are actually different. So if you see that in the 2015, like we saw, there it was a 3-tiered system: low, intermediate, and high. However, in 2025, it is 4-tier: low, low intermediate, and high intermediate, followed by high. And then there is also a lot of data as compared to 2015, when we hardly had much of molecular data about the thyroid cancers. Now a lot of data has come up, and a lot of targeted therapies and other treatments have come up. Even we know the tumor mutational burden, and then the role of even the immunotherapy is coming up in at least the the poorly differentiated and the anaplastic cancers. So that also can be taken into account, and still there is some controversy going on, like in the previous lectures also. BRAF positivity, do we need to change the treatment, RAI and all? But we do need that like BRAF positive with TERT, or BRAF positive even with RAS can be more aggressive. RAS with, usually BRAF and RAS will not be together, so RAS with even your TERT would be a more aggressive variant. So we can tailor our treatment to some extent accordingly. Then the first dynamic risk stratification, earlier it used to be usually earliest by 6 months, but now it is usually can be done fairly at 3 months. And response categories, they have still kept it the same, 4 categories: excellent, structurally incomplete, biochemically incomplete, and the indeterminate. But they were not that precise. Now they have given even better definitions. And for the radioiodine, I think we had a lot of discussion on that. There has been some I think suggestions to even de-escalate the dose of radioiodine. But I think still that has been given in a range, and it is as per the nuclear medicine consultant decision. So that has to be taken in consideration with the nuclear medicine department. And this framework, we know there was no methodology earlier, but now it looks more like more standardized in a more methodical manner, which is a data cycle integration. So what is the take-home message? The take-home message is dynamic risk stratification actually personalizes the thyroid cancer care beyond the initial static staging. And ATA 2025 further emphasizes the earlier and repetitive assessment of these thyroid cancer patients. The response categories, they are similar, they are same actually, 4 only, but they have better definitions. The dynamic risk stratification is now embedded in data framework, and this has a prognostic value. It can help us in taking decision with patient regarding the escalation or de-escalation of the therapy. With this, I conclude my lecture. Thank you so much. If there are any questions, I am open for that.
Madam, for DRS, the duration was mentioned was 3 months post-surgery. And if any adjuvant therapy is to be given, then after 6 months of the adjuvant therapy. After that, what is the duration? Is it mentioned in that DRS?
So I think the more important point, rather than after 6 months, the treatment, after the completion treatment, the more important point here is that we are now intervening early, I would say. So I think, even though I have read this 2025, but my interpretation was this only, and I'm not sure if I have missed that, sir or ma'am, if that is something else is there.
DRS was introduced by Mike Tottle from Memorial Swan Catering, and it's not 3 months, it is actually after surgery when you should assess. That is for first A. A is between 6 weeks to 12 weeks. That is the first assessment. You do not have to rush within 2 weeks, 3 weeks, patient is hypothyroid, go and don't have to. You can wait for 6 to 12 weeks. Then you actually assess the risk of whether we want to treat or not want to treat. That is stratification. So the first R is response after surgery. And then you decide, okay, the patient I want to treat, And if you give radioactive iodine, they have given in the table, they have classified those people who are given total thyroidectomy, neck dissect plus minus neck dissection with iodine or without iodine. So the range of for TG is different for both
Yes.
groups. So they have classified.
They are different.
So after the giving radioactive iodine, if you are given, when we should do in 2015, they told it is after 2 years. But this was all applicable for the adult because Memorial Swan Catering, all the surgeons who are publishing, all only they see the adult thyroid cancer. They don't, like in India, we see from my patients ranges from 3.5 years to 95 years. So we see all grade. But in US, if you are 18 years old, you have to send it to the adult center. So pediatric and adult patients, they don't see each other. That's why there is 2 guidelines in 2015. One is for adult. Earlier, before 2015, they used to extrapolate for the children, which was wrong. And the first time in 2015, and the new guideline for pediatric is on the process. It will be available end of this year or maybe early next year. So there, we used this strategy of using this adult parameters, whether it will be applicable in children. We followed 176 children over more than 10 years. We demonstrated the same is also applicable in children and got published in Journal of Clinical Endocrinology Metabolism. That is, I am sure this will come in the new guideline.
Yes. So after that, it is not very much clear.
Not clear in the
Yes,
guideline.
yes, yes.
You have to do after 2 years of treatment, not DRS will be applicable after 2 years of initial treatment.
Okay, thank you, thank you.
When do you call the patient again for
If
checkup?
it is children, we got at 1 year, and if it is adult, between 9 to 12 months.
9 to 12 months next. Okay, thank you, sir.
Can I ask a question? Is that okay?
Yes, yes.
So sir or Archi madam, so like you also mentioned, sir, in new 80 guideline they mentioned clearly that we should be assessing it 6 to 12 weeks. So does that mean that we should start off? Yes. So we should start thyroid medicine for all our patients and then do a biochemical assessment. Should that be unstimulated TG? How should it be there? Say if it's a low
Yeah, if it is a low risk patient, you can have time, whole world is on to you, can give thyroxine, after 3 months call the patient, on non-stimulated thyroglobulin is less than 10, you don't have to do anything.
They've also sort of said that do a RAI scan for risk stratification is okay.
Yeah, you have to do risk stratification if thyroglobulin is more than 10, stimulated thyroglobulin. And if it is more than 1, again you have to do risk stratification. All this guideline changing is more synthetic changes than actually they are
Actually,
doing.
sir.
So the intermediate is called the big, so
Yes.
you separate it up
That's
or
what I'm
lower.
saying.
This is all synthetic. There is nothing. This is a continuum. The life is continuum.
Actually.
It's not in boxes.
So the earlier guidelines were in continuum only. Now they have put it in like